Good morning, George. It's another Tuesday morning, and we have a phenomenal guest today. Somebody that's going to talk to us about the problems, the perils, and the future of healthcare financing in the U.S.
Yes, welcome, Dr. G. Bai. The topic that we're going to be speaking today about is the finance of healthcare in the U.S. and how it limits consumer choice and competition. Take it away.
Dr. Bai is a PhD, CPA, engineer, bachelor's in Japanese, professor of accounting at the John Hopkins Carey Business School and Health Policy and Management at the John Hopkins Bloomberg School of Public Health. An expert on healthcare accounting, financing, policy. She has testified in Congress, written on the Wall Street Journal, the Washington Post, published her studies in leading academic journals such as the New England Journal of Medicine, JAMA, and Health Affairs. Her work has been widely featured in the media and cited in regulations and congressional testimonies. She was a visiting scholar at the Health Analysis Division of the Congressional Budget Office. She teaches graduate courses and has received the John Hopkins Alumni Association Excellent Teaching Award. She has served as an expert witness in litigation, arbitrations, and provided consulting services to the investment community. She regularly writes for Forbes. Welcome, Dr. Bai. What a phenomenal life story you have.
Thank you so much for having me, Dr.
Yes.
Raba and Dr. Rogu. This is a huge honor for me.
Dr. Bai, how does one go from getting a bachelor's in Japanese language to engineering to becoming an expert in healthcare economics in the US?
Thank you. The bachelor's degree in engineering and Japanese literature in China, that's a combined degree. I had never been exposed to healthcare at all until I came to United States, entered the doctoral program in Michigan State University, focused on accounting. At that time, I was interested in using good data to answer accounting questions. But good data is very limited for governance, board member background for nonprofit organizations. Then hospital became such a great research setting because in California, at that time, California hospitals disclose their board background. So I use that data to answer accounting question. But then it opened the door for me to this fascinating world of healthcare. Then it's really by accident. I got interested in healthcare because of the data exposure. Then ever since I got more and more deep into this field, and it's just so much fun. I do not want to go to any other field for research.
Wow. I want to level set a little bit because even though our audience is mostly pediatricians and physicians, and we live and breathe this every day, these problems, we don't really understand the macro picture. What are we spending on healthcare and who is paying in the US?
We spend right now the $1 trillion on healthcare. That is solely paid by taxpayers and American workers. So people might say, oh, it's actually paid by employers. Look at the employer-sponsored health insurance. I would say no, because employers are acting as fiduciary to take a portion, our salary, away, put into this benefit administration, and then they serve as a fiduciary to manage the healthcare benefit. In other words, they buy insurance for us, they manage the money for us. As a result, we have a lower take-home pay, but in exchange, we get the insurance managed by our employer. So that's how it works. But then you might say Medicare, Medicaid are government programs. So it's not paid by us. Government money always comes from taxpayers, either deceased, alive, or to be born.
Yes. So the numbers are staggering, right? It's reaching 18 to 20% of GDP.
Yes.
And commercial insurance, which is a misnomer. So commercially paid finance of healthcare in the US accounts for over 1.3 trillion or 30%. Medicaid accounts for over 800 billion or 20%. And Medicare for almost $1 trillion or 22% of our cost. So that leads me to the next question is, does the US have a working health insurance market?
I would say it's highly functional. Why? If it's a good system, I would say the performance should be making everybody relatively healthy and then using limited resources. But we're really compromising our patients on both fronts. Number one, we are really not seeing excellent health outcomes, right? If we compare with other developed countries. Second, we are spending so much money. And there are different numbers, but I think there's consensus that there is huge wasteful spending in our healthcare system, meaning that only a portion of the trillion spending is actually helping our patients. And many of the the dollars spent are for, I would say, irrelevant or actually detrimental purposes.
And so from comparing this to a true insurance market, for example, my auto insurance or my home insurance, the healthcare companies that manage the transactions, because they're really not insurance companies, they're in the business of managing transactions and managing physician networks like United Healthcare, Aetna, Cigna, Humana, Oscar Health. They have maybe 4 major buckets. Medicare Advantage, which became the shiny object that everybody chased for big dollars. Medicaid MCOs, which is in many states just a fairly simple contract. In New York, the state of New York pays United Healthcare $200 per child per month that they manage the cost of those kids. And they give them, in the contract, they stipulate what services they must provide. And then then United Healthcare does United. So they're not at risk for those dollars. And then a claims and network administration that they do for many of the large employers, like you would think Google, IBM, my dad's old organization, the American Organization of States, which are self-insured. The company takes the risk. The insurance just provides the network and manages the claims. And a very small number of it is a real at risk where they're selling to individuals or small employers. And if someone ends up needing to have a bone marrow transplant and then be on dialysis and cost $3 million in 1 year, Aetna or Cigna or Humana are going to be on the hook for that cost. So that totally distorts the market because they're making money from transactions. They're not managing risk, and they're not pricing my policy based on the risk I bring to the table. Unlike any other insurance that I buy. My malpractice insurance is rated based on where I live, how litigious it is, what specialty I have, how many claims I've had before. My car policy is based on how old my car is, how expensive it is to drive, what neighborhood I live in, what my age is, and what the risk is that I will get in an accident. So if I want to insure a Maserati with 2 doors that's colored red and I'm 23 years old male, I'm going to pay up the nose for that. But if someone my age is driving a Toyota Sienna minivan in a safe neighborhood, which is very cheap to repair because the parts are all over the place, my insurance premiums are going to be very low. That is not the case, right? That's totally not a functional market.
Correct. This is a great summary. I think my overall take is that blame the game, not the player, right? So the insurance companies, even if they want to do what you just described, like looking at the background of each individual enrollee and decide how much premium should be, even if they want to do that, they're not allowed to do that, right? Because we have very restrictive regulations on, like say, ACA and also all the public programs. So you can't rate, it's actually called a risk rating. We have to do community rating. So that means even if you are very health conscious, you do all the right things, you cannot really save on your premium because right, you have to be contributing to this big risk pool and helping other people. So that actually creates a problem that removing the incentive from individuals to improve their health in order to get financial benefit, right? If you choose a terrible lifestyle and I choose a good lifestyle, guess what? We're paying the same premium. So that is a problem. Second, as you already mentioned, the incentive is wrong. If an insurance company is providing the administrative services for self-insured employers, this is really just percentage-based business. Higher spending higher income. So can we imagine that insurance companies would be happy if the total medical spending for the insured employers go down next year? Because that will hurt the insurance company's revenue, right? So this perverse incentive tells us that there's just not enough reason on the market for the insurance company to do the right thing. And if I may also add that our understanding of insurance is actually very much away from the efficient use of insurance. Insurance, as you just mentioned, for a car, for a house, is really to insure the major financial exposure, right? If we, let's say for auto insurance, if we add changing oil or changing the wipe to the insurance coverage, number one, our premium will be very expensive. Number two, the price actually paid by insurance company to do all those things will be high. Why? Because that's hidden from consumers. Then eventually we are at loss. That's why on those markets, we don't even see the small things being included, because that kind of insurance plan absolutely has no market. Nobody will buy it. It's too expensive and will be priced out of market. But in our house insurance market, people have this notion that the broader is better. So we have all the generic drugs covered. We have, let's say, primary care doctor visit covered. And that creates a lot of inefficiency. Maybe we're actually paying a much higher price for those routine, cheaper services than if we just go to cash-based. And then primary care doctors, as you mentioned, are now integrated into systems in many cases. And then by going to the insurance contract, the primary care doctors, you end up getting referred a lot to the system-affiliated hospitals, and then you're doing some unnecessary things. But overall, we don't have the right incentive by contracting insurance for our current system.
Very well said and explained.
Yeah.
To me, the analogous situation is the contract negotiations between the county employees and the county elected officials. And they sit at the table. The county employees usually are the biggest supporters of the elected officials. They give them great pension plans, great health insurance plans, great benefits here and there. And then they promise to pay it, and the taxpayer ends up paying the bill, and there's not one responsible adult at the table. So when these mega systems sit down with an insurance company, they both benefit by raising prices. Because if, call it, Herb Bravo's health system integrated of Long Island can get $1 billion as opposed to $500 million, I make 5% of that $1 billion. So the higher the price, the better. And on the insurance side is the same thing. They make a 5% return. So they're incentivized to raise the prices as much as they can do. And the rest of us just go along for the ride and lose the opportunity of getting pay raises and using our money in an effective way in a capital market that's free. It's a shame. So I'm going to touch a little bit about an area that is tangential to this, which is a fascination of mine. Why are small businesses good for your community and the economy? What do small businesses do in America for the economy?
I think this small business are indispensable part of our economy. Actually, it's a dynamo for our economy. People might focus on large corporations, but remember, the small economies are feeding both ideas and resources to the large corporations, and especially for small communities. Those small businesses are really the blood and all the end resource for a community. Imagine who's hiring people, right? Without the small businesses, without the employers, we will have a stagnated and hopeless economy. So I think it's utmost important for us to make sure the small businesses have a good environment to survive. But as you mentioned, anytime, whenever there is regulatory capture or regulated state, the purpose is, and I will not say the main purpose, but one of the main purposes will always be prevent pre-competition. Because only large ones, right, can deal with regulatory compliance costs. And then they also have political connection. Then they will use the regulatory opportunities to erect barriers for small ones to enter or compete. So as a result, you will have a very friendly environment for big ones and a very unfriendly environment for small ones. I think that we all should be very aware of this phenomenon, and it's true almost, I have to say, everywhere. Whenever we see this kind of regulatory capture, and we see the regulations put there, always backed by large players to fend off competition from small ones.
Yeah, what's happening in independent practices is the small practices basically are the small businesses, and the environment is starting to be real hostile to independent practices. What I cannot comprehend is insurance carriers will pay an independent practice X amount of dollars for an office visit. That same practice that's captured and taken over by a big entity now, same doctor, same place, same service, but with a different tax ID number of a larger corporation or entity, they're paying the same service 3 times the cost. How is that not wasteful spending?
And this would not happen. Sorry, Dr. Rogu. So this would not happen if it's really a direct transaction, right? Because patients, when they use their money, they will think, oh, if I pay 3 times, do I get 3 times better? Maybe high-risk patient might choose to use facility-based services, right? But I think the majority of the patients will say, whoever's cheaper and whoever give me good service, I will go there. But that kind of feedback loop is not there when we're talking about large insurance companies dealing with businesses. And no, as I mentioned earlier, we have a lot of perverse incentives. So there's no reason they should treat small business, because they just can't. They can take advantage of them.
So for our listeners, there's always been an interest of mine. Most new jobs in the US come about from innovation in small businesses. That's the hiring engine of the country. That's a growth engine of the country. A single FDA pediatrician will gross between $600,000 to $800,000 a year. So let's say it's $1 million. Most accounting experts and economists will tell me that is multiplied by a factor of 7 in my neighborhood. So if I run a business that has $1 million in gross receipts, because of the employees, the taxes, the rent, the services that I use, that is multiplied times 7. So my small business is contributing $7 million to the economy of the town that I live in. And that is incredibly important for people to remember. And then if you're going to live in a free, functional, capitalistic system, we have to have competition and we have to have customer choice. When everybody works for her Bravo mega health system of Long Island, there's no longer competition, innovation, or choice for the customer. We're just Mama Bell from 1970s that had no innovation. You got your phone service from one company and it worked, but it wasn't going to produce a smartphone, a cell phone, the internet, because they had no reason to. They had so much money coming in, what the business people called their cash cows, that there is no reason to disrupt their model. And the real innovation in telecommunication occurred when Ma Bell was broken up into 5 different companies, and then they had to compete for your business. And we got all kinds of great things out of that. It is extremely important from a policy perspective that we support small independent practices that add innovation, competition, and choice to the customer. And the reality is, in many communities that are underserved, that are indigent or poor or marginalized, only an independent practice will take the risk of going in there.
Yes.
The big health systems don't want to touch it. And they'll buy it and they'll close in 6 months. We can't sustain it. Yep. We just can't lose any more money there. We're gone. Or the private equity will do the same thing. They'll buy a bunch of pediatric practices, think that they can make them make millions, which is not possible. And then they'll go, didn't work, fire everybody, we're gone. And that's not good for anybody. The other problem that I see in healthcare financing is, you alluded to a little bit about it, but it's really the cost shifting. So the person consuming the service is completely oblivious to what it costs to get that service. They think it's a $30 copay or their $50 deductible. They don't know that the bill was actually $3,000 or $4,000 or $5,000, and they don't care. So that's one problem. And the other problem is that Medicaid pays so little for the services that people receive that everybody else has to be taxed again. Not only you're being taxed in your federal income to support Medicaid, but you're also being taxed at the state level to support Medicaid. And then your health insurance premium skyrockets because the commercial payers are paying, like New York, it's at 45% of Medicare. So they're paying 200% of Medicare. So that's 5 times what Medicaid pays. That money has to come into the health system to subsidize how little the state of New York pays for the care that Medicaid patients get. What are your thoughts about that?
I believe government programs and the payment, very arbitrary payment decisions are the primary driver for this hostile environment against small practices. As you said, in New York, if you look at North Carolina, same. The payment rate for the same service in hospital setting is so much higher than for independent physician practices. I think this is, to some extent, really is the inevitable outcome of the capturing we were talking about. And we're seeing this everywhere, not just in payment, right? Medicare, Medicaid payment, but also we are seeing restrictions on physician-owned hospitals, which is already being shown by our study, 30% cheaper than their competitors, even in the same county. And also we have certificate of needs law, right? If you want to start something, it's almost impossible unless you get approval from the incumbents. So the system almost appears to be designed in a way to push independent practices to surrender to big corporation, either to be integrated into the large systems or being bought by private equity firms. So I think whenever we want to have competitive market, have small ones to survive, we have to make the regulatory barrier very, very low. But we're going to the wrong direction. The cost of doing business is so high, so you cannot blame pediatricians or any physician to sell their practice, right? It's just a no-brainer. They can get a higher pay from systems or by the private equity firms. They have to make that choice. But if we are going to a relatively free market, let patients choose, as you mentioned, it's 30% cheaper, this physician in the hospital versus their competitors. So patients will, from their own interest consideration, choose to use independent practices. This is very different than, let's say, Walmart going into a town and kill all the mom shop. It's different because Walmart really actually cheaper. But in our physician market, it's different because independent physician actually cheaper than the large system. But patients are not allowed to choose or not allowed to be aware of the situation. That's why I think the market is just extremely unfriendly due to all the regulatory constraints and uneven payment, all designed by the company.
Yeah, I used to think that in order to have an independent practice, the first thing that you needed to have is a medical degree. Yeah. And then you could have an independent practice. Now it seems like any MBA suit can become private equity and buy a practice. How is that right? Because there's regulation to prevent that.
I think, thank you, Dr. Wu. This is a great point. The reason is that skill, that sophisticated financial skill is extremely valuable now, but was not valuable then, right? Before, the environment really does not require sophisticated financial skill for independent practice to survive. But because things are pretty simple, straightforward. But now things are getting more and more complicated. So the financial skill becomes much more valuable on today's market. That's why they got the niche and take advantage of it.
Yeah, a lot of the hospitals and corporations and things, they have in the leadership, they're no longer physicians. It's just suits. Right. Tell physicians what to do. The worst thing that you can do as a leader is tell a physician what to do. You will get an automatic no. regardless if it's the right answer or the wrong answer. I'm seeing a lot of physicians that have lots of years of experience. They went on and they did MBAs, and then they go into a leadership role. And those people seem to be a little bit more successful. But when it's just, I remember when we had this program called Disrupts in New York a couple of years ago. And I would have this MBA student that used to come to me, and I would have to report to him some quality metrics, give him basically some silly Excel files that he could upload. I used to give him a hard time just for sport. I would always do what they needed, but until he got it, I really tortured the guy. And I felt bad sometimes. But if it was a physician, if it was Dr. Herb MBA, I would have given it to him immediately.
Yeah. But
That's bad. That's bad.
So I wonder, do you think that these were unintended consequences by the politicians and policymakers, say the Obama-Biden administration, when they built the ACA? Or was this what they had in mind? Such a burdensome regulatory environment that everybody would end up working for the government at one point?
I think it's probably both. If, let's say, on the extreme side, let's say if there's such a bad intention, they want to control everyone. If that's the case, then it's much harder to control if everybody's independent, right? It's much easier to control if everybody is somehow incorporated into select the number of corporations and becoming employees. So that's much easier. But I think there's also unintended part. This is really not, it's not a partisan issue. I see a lot of politicians on the right also support anti-competitive and hostile policies against physician practices. In their mind, I think they don't really look at the root causes. They're looking at, I would say, very temporary, short-term focused solutions. And then that just, as if you have a small thing, you patch another Band-Aid, right? And then it does not work, you patch another Band-Aid. So you make this system more and more complex. Think about just Medicare payment. How many different revenue streams can a hospital get? Or a physician practice can potentially get? Because you guys are physicians, then you don't really know the nitty-gritty details and all the back doors to maneuver, to exploit the system. That's why you don't get into leadership position, right? But let's say I'm an MBA, I'm not a physician. However, I'm very much expert on Medicare payment system or Medicaid payment system. And I know all the loopholes. And I know all the people, the right people. So I can bring a lot of money unrelated to patient care, to the hospital, to the practice. Guess what? Then I will be in the leadership position. So I think there's both, unintended and intended ideas. But also think about all the regulations and state and regulations and legislations. Who's backing them? Who's trying to push them, right? Always large interest groups. So why would they spend their money and energy to push those bills? There must be some good result in return, right? So in most cases, the return is a much more friendly market post passage or post implementation of the regulation. So what would be the favorable outcome if you are running a business, right? Would be remove competitions and give me a free run to capture the market. So
it becomes a monopoly. I thought monopoly.
That's the intention. That's why I push the bill.
That's what they want. They want to have monopoly power.
Yeah, but I thought monopolies are illegal. Didn't they try to take down what's his name from Windows, Bill Gates, because they thought he had a monopoly on the software business?
It's like anything else. It could be illegal as long as the government does not prosecute it. You can get away with it. And the federal regulators took the perspective during the Obama administration that they were not going to use. They had an old rule for healthcare mergers that if you had more than 30% of the local market, they would fight you to not allow you to merge, whether you're a practice or a hospital. And the Obama administration waived that and allowed people, like in my market in Northern Virginia, Innova Health System owns 85% of the hospital beds. Before Obama, they would have not been allowed to buy one more hospital past 30% of the beds, because that was the safe haven that DOJ had said it was okay. But once you cross 30%, you had monopoly power and they weren't going to allow it. So it's all about what the regulators want to enforce. And they didn't want to enforce it. To Biden's administration, the person at the FTC is very aggressive about enforcing antitrust law and very aggressive about taking away restrictions where physicians can work, or I forget what the term is, the restricted covenant that is in a lot of physician contracts. So you basically have to leave the state if you leave your employer. They're doing away with that. But it's all regulators decide what they regulate.
And I want to piggyback on that. I think monopoly in many cases actually government granted. Right? If you look at the passage of ACA, there's a provision saying we cannot establish or expand a physician-owned hospital. How did that clause get there? It's because it became a political horse trading. So the hospital said, if you want me to support Obamacare, then you have to insert that clause. Otherwise, I won't support you. Then this is government granted monopoly, basically killing of all potential physician-owned hospitals to emerge and compete. So there's no way to challenge government granted monopoly. Same with COVID testing as well, right? It's only actually $1, $2, but then we are paying initially $30 for the at-home test. Why? Because FDA only gives 3 companies or well-connected companies the right to produce and contract and be bought by government programs. So that is government granted monopoly. That's why I think that this is a fundamental issue and very difficult to break.
Talk about wasteful spending.
Yeah.
But then I would also add the benefit, if you're a politician, actually, you will do the same. Why? You create this kind of government grant monopoly, and then they will help you politically. And it's a no-brainer. But if you say, okay, people, you take power, then you don't have the corporation support you, give you all the benefit. It's much harder game to play. Therefore, I think it's politically beneficial for politicians to take power away from patients in the name of protecting them and transfer the power to large connected business interests and then get the support backdoor. So that's a game being played.
Wow. And so we're going to touch on a couple articles. The first one is one that was published in the Journal of the American Academy of Pediatrics. And its core tenets are that every child in the US should be insured by Medicaid from birth automatically until the age of 26. And the second tenet of it is that Medicaid needs to be changed from a state and federal partnership to a federal funded entitlement program that will reimburse at or close to Medicare rates across the nation. And they think this is aspirational, and they found the next nugget of gold. The first thing that I will say about this poorly written paper is that it was by 3 academic physicians, colleagues, very well respected, kind-hearted, God bless their heart for the work they do, that have never run a business or run a primary care office. So it is idiotic to ask people who haven't run a business to have an opinion on how you make money in a business. So that's the flaw. Second of all, I'm going to say that if we implemented this and the government was paying 45% of Medicare rates for every pediatrician in the country, the specialty would cease to exist and there would be equity. There would be no access for anyone except for the children of Bill and Melinda Gates, who can pay whatever they want to pay. The rest of us would have no access. Now, my friends who are nurse practitioners will say, we'll come, we'll step up, we'll take care of it. No. Nurse practitioners, 70% of them do not want to go into primary care. So they're not going to come in. And to those on the other side, I say, yes, it's doable. Cuba does it. In Cuba, the pediatrician makes as much money as the school teacher, as the bus driver, as the trash collector, and they still have pediatricians. In America, we don't pay the school teachers well, and there's still people doing the care at what the school system decides to pay them. But you're not going to get any choice you're not going to get innovation, and you're not going to get high quality care. I have one more, and then I'm going to ask you for your thoughts. And it is that this is the most ignorant thought process that I have seen in a paper in healthcare financing. The problem today with the Medicaid program, which is a program for the indigent, is that the majority of the spend is in the dual enrollee elderly patient in a nursing home or at home requiring significant amount of home health dollars. And what I call this in the exam room, this is a disease that hurts today. You sprained your ankle, it hurts. You're going to come see me, whether you have the money or not. You put in the credit card, you borrow it, you want to get an x-ray, you're going to want to get a boot, and you want to get your foot to stop hurting, because without it, you can't walk. There's diseases that don't hurt. For example, you can run around with a glucose of 400, your kidneys are dying, your heart are dying, your eyes are dying, you're causing damage to your whole body every day, but nothing hurts. So you won't come to the office, you won't get a glucometer, you won't shoot yourself with insulin once a day because there's no pain factor. So the pain factor here is you cannot take an elderly person that's infirm in a nursing home and throw them out in the street and say that we are a society. But then we got to cut the spending somewhere. So we're not going to invest in the children who are the future of our democracy, because they're not causing us any pain. For the most part, they're healthy. So why spend any money on them? So to me, to put the kids in with the elderly, infirm at the end of life in the same bucket, it's like putting K through 12 education into the military budget. The moment that we are at war, we'll close all the schools, because if we don't win the war, there is no future. What are your thoughts on someone saying this is aspirational in the future of our specialty?
Thank you. This is a great comment. I think people have different priorities and different aspiration. I think the intention is extremely good, right? But we will have to come back to money. Like, I'm an accounting professor. I think we don't believe money grows on the trees. We believe if you change incentives, people's behavior will change. If you pay the pediatricians 1/10 of what they get today, you won't get the best and brightest people to enter the practice. And then, yeah, you end up with either rationed service or extremely low quality, etc. So they ignoring physical reality, I think, is a common theme in today's rhetoric or narratives. And the belief that physicians will do whatever. Physicians won't reduce supply, won't change behavior if we change the payment system. I think it's just a not realistic understanding of how economics work. I do not believe since there are people who just said, no, there's no such a person. We are all living and working driven by economic incentives. And I also don't believe anybody can design a system from top down with perfect knowledge and design a system perfect for everyone. It won't. It has to be, let the people decide, right? That's why we, the people, is our spirit in America. Simply because the planners don't have any clue. I often heard people saying, because government said so. But no, what is government? Like what you said, the Medicaid, young children and older seniors, these are people sitting in a building in DC. Do they have superior knowledge? Or do they have a superior experience or superior morality? I doubt it. So we should always question the logic of all these, as you said, it's unreasonable policies. There is really no other force to counter that except for people's awareness. If we question that, if we understand where it comes from and the limitations of the policymakers, we keep chattering. And that will have, I believe, that will have a ripple effect, and that will become a force, and maybe a very powerful force to prevent all those reasonable policies from hurting the efficiency of the economy. At the end of the day, if we let pediatricians, let physicians have freedom to innovate, to help patients, why would you choose to go to medicine? Of course, medicine pay well, but also you want to help patient to start with, right? I really believe physicians are the key to change, to reform, transform our healthcare system. I'm not talking about innovation just like new drugs, etc., but innovation to save money, innovations to provide affordable care to patients. Like in rural area, like system cannot do it. Private equity cannot do that. But maybe you and I, we can form a very efficient form, and maybe we can make it it's run extremely fast and not using much labor, but deliver great quality. We can do that if we are allowed to, if we, especially in a very relatively flexible payment system. So that's my thinking about why we have this top journals of publishing people with great intention, but have, I would say, some limited understanding how money and how economics work.
I think what you're describing is practice transformation. Practice transformation transformed from paper to electronic health records to access to care to population health. This is practice transformation. An independent practice is capable to do that because they're smaller, they're more nimble, they pivot, they can do things. If I decide I want to do something in my practice, implement one of those scribe AIs, I can do that. I don't have to have 15 meetings to have a meeting with Dr. Bravo to talk about which one should we get. And then the one that benefits me as a person mostly because it's my friend or something, that's the technology that's picked, even though it's really complicated and cumbersome and the physician will hate it.
Right.
Hospital systems are still the same, maybe with computers, they're more fancy. They have Starbucks and Panera in the lobby, but it's still the same old hospital that we worked in as interns, Herb.
Yeah, I think Dr. Bai's point here is that when there is a central regulator forcing people to do this, everybody to do the same thing, it doesn't work. And when people do not understand basic tenets of accounting and economics, and there's a behavioral economics, a whole science of economics, they will have great intentions and incredibly smart people, but they will propose the wrong solutions. And we saw this already play out. The electronic health record is not a bad idea, but it was a terrible thing for the patient. It destroyed the patient-doctor relationship. It did not improve care. It did not control cost. It spent a lot of money that went to people in California that created EHR companies. And that was just central planning gone awry. And there was going to be a point where the electronic health record was going to be like your smartphone. People were going to want it, and they were going to use it, and it was going to improve things. And that opportunity was lost. And we never put that cat back in the bag, because to change the way EHRs are used today would be a $20 billion solution. And the government doesn't want to finance it, and the private industry doesn't want to finance it. So we're going to be putting, as the doctor said before, Band-Aids on a poor policy to try to make it less bad, but we're never going to make it good. And that's a big problem. That's a big problem. You wrote a wonderful article about the problem with the North Carolina Medicaid expansion and what that is going to do to independent practices.
That will have a crashing effect on independent practices, because it tells independent practices you're going to get only a small portion of what you would get if you are integrated into a hospital system. So that make a very uneven playing field to the favor of hospital systems, but really hurting independent practices. So the result will be not only the private payers going to pay more money, but also give a very important force to push more and more integration. was the demise of small practices.
And the problem there, if I understand your article correctly, is that and I will say the name Novant. Novant is the major player in North Carolina. They're supposedly a not-for-profit. I don't know if that is true or not, because there's a lot of writing in the press about their funds in the Cayman Islands or somewhere in the Caribbean. But they pushed that Medicaid at the hospital system has to pay on parity with their commercial contracts.
Correct. Yeah.
But the independent physician will not be paid at that rate.
Why is that? Because independent physicians don't have political power. The government of North Carolina needs political support to pass Medicaid expansion. So in that process, independent physician is not a very important constituency to please, to get support from. Therefore, but the hospital is a very important political force. So government has to make hospitals happy. Does not care if the physician is happy or not, but they have to make hospital happy. And the hospital said, you know what, if you want to support you in return, you must pay me the commercial rate. That's how the deal is reached. So what we are seeing just inevitable consequences of this political horse trading. But that comes back to who's controlling the money, right? We are going to make whoever gives us money happy. That is universal rule, right? We don't care if you don't pay me, you're not my customer. But when government pays the money, I need to make the government happy. So that is why the hospitals have the ability to make government happy. I'm going to support you to pass Medicaid expansion. Then I get more money from you. So that transaction has absolutely no relationship with patients, right? Patients are out of this equation. So that's my fear, my concern of where we're going to. We are going to move toward a system that the providers are contracting with government, because government provide all the money. Government get the money from taxpayers and then get this big chunk and then allocate, right? So government has all the power. Then as provider groups, you don't need to worry about patients, because patients have no money. Then you only make government happy. Then the government will give you more money. And in this kind of game, you see the political power becomes much more important than any price, cheaper or quality better, value higher. It has nothing to do with that. It's all about my relationship, right? What kind of benefit I can bring to the policymakers. That is not a system that will help individual patients. In that system, individual patients have absolutely no power, although in the name, they're being protected.
Wow, sounds like organized crime to me.
That's what
socialism.
I'm worried about, this marriage between policymakers and special interests. In this case, we're talking about hospitals, right, and insurance companies. And that is inevitable when the government spend money. They have so much power. Let's imagine government is not controlling the money. Then there's no reason, right, that business would bribe a government for benefits. Yeah.
And then who's going to pay this bill?
Our taxpayers, right? Taxpayers, American workers. And let's say this system really helps patients. Fine, we spend a lot of money, we're really helping patients, but are we really helping them? Let's think about Medicaid patients. Right? If I'm Medicaid patients, I got a lot of money actually spent on me, at least on the surface, right? Based on the report, so subsidized to me by taxpayers. But do I have the right to choose providers? Do I really get the money? No. I only get the money through this coverage, right? So if I use whatever services, I got covered. What if I become more like health oriented? I choose a better lifestyle. Can I get more money back? Nothing, right? And then I'm being allocated so much money, but I cannot even, let's say, see Dr. Bravo. I think you're great. I want to see you, but you don't take Medicaid patients. So I have no option. Imagine if the money, some portion of it is controlled by myself. Then I can say, I am equal as all other patients. I can go there to see Dr. Bravo. I can pay this amount. We are truly equal. Right now, we are really making a caste system that's not helping patients in need at all.
Absolutely. I have one more observation, and it is not just about the money. The hospital systems have such tremendous power because of almost any county in America. your local hospital is one of the top 10 employers.
Right.
So whenever the politicians say, we're going to do this, the CEO shows up and says, George, I'm still going to vote for you, but I'm going to have to fire 100 nurses from my health system because of this policy that you're going to vote for. You think they're going to forgive you when you have to get reelected next year?
Yeah.
And the conversation ends, the policy ends. And that is not even just about the money. It is the threat of the number of people I'm going to fire. And they're all good middle class jobs in the community. And I'm one of the top 10 employers. And by the way, they're all women. Do you really want to make the women angry? Because they vote.
Right.
And that's the hammer they use.
Oh.
And it's a very effective, persuasive conversation.
But I think that come back to money, if we think how to counter this, right? So let's imagine, we have to dare to imagine, to envision a system. Let's say if patients have some control of their own money, let it be Medicare, Medicaid, commercial patients, then we will have think about restaurant. Right now, the government or policymakers want everybody to have the same restaurant, same meal plan. But if everybody controls the money, guess what? Physicians like you might choose to have Michelin restaurant. You might choose to have McDonald's. We will have diversified provider offering to cater to diversified needs. And then the big restaurants, right now the hospital dominant, they're going to observe what's going on in the market and then they adapt. That is how small business, small practice drive innovation, drive the change. So I do think how to change this, all this system, right now looks like hopeless system, is to let people control their money. Once they can feel the benefit, they will stay, they will vote with their feet. And then independent practice will have a chance to innovate and to capture market share.
Yeah. So I want to talk a little bit about someone that I admire very much. I don't know if you've read any of the writings by Mark Bertolini.
I have not.
You should. Mark Bertolini was CEO of Aetna, okay? And he came into the health insurance market out of his own personal experience. So he almost lost a child to cancer. And then he had a traumatic injury skiing. And he was very passionate that you can make money and you can do good. And he realized that Aetna could not survive in this agglomeration of insurance health plans that it was happening. He tried to merge with Humana, but it was blocked by the antitrust regulators. And then they turned Aetna into a retail store. It merged with CVS. And CVS won the better battle in the boardroom. So the CVS executives control Aetna. And CVS has now become, their idea was that they're going to enter retail primary care because they have a store in every community of the US and they could do it better and cheaper than anybody else could. And then they saw all the dollars coming from Medicare Advantage and they went full throttle ahead buying more Medicare Advantage providers and giving more incentive to Medicare patients to join the Aetna Medicare Advantage plan. And now they're up to a $900 million loss. And what happens in our industry when you lose money? We have a dear friend who is a consultant for pediatrician, and she says, when the health plan loses money, it starts looking for people to get haircuts. And it's not the hospitals and not the big groups, because they have long-term contracts with them and they can't do without the hospital. So they go after the independent physicians and they give them a haircut. Because now they're losing $900 million in the bucket of Medicare Advantage. They're going to make it up somewhere else. This distortion of the market is very harmful because, and I see their point. If I was a negotiator for Aetna with Dr. Rogu, I would say, You're willing to take $45 for a Medicaid patient for a 99213. Why should I pay you $46? Tell me. There's no reason. You can provide the care for $45 to a Medicaid patient. You can provide it for $46 for me. You don't deserve a dime more. And that's a totally reasonable argument. The problem with it is that they're doing away with the independent practices. And the premiums are skyrocketing. So before the pandemic, they were about $18,000 for a single individual in the private market, $28,000 for a family. Now it's more like $35,000 for a family plan. And if you really are going to pay $45 and there's no cost shifting, the independent practices can't provide the care. They're going to run, they're going to be out of business.
Yep.
And that's tragic. And as you alluded before, it is in the best interest of the big medical care organizations and the health systems to have no one else at the table but the two of them, and raise the prices every year. That's in their best interest. What are your thoughts? Any ideas how we could change this narrative?
I think if we are the CEO of those large companies, either hospitals or insurance companies or other corporations, we probably do the same. We respond to incentives. I really, in my research, I don't really look at, people's morality, etc., because that is on the margins, less important, in my opinion, as response to incentive, which is universal. So we have to have enough public awareness and political will to loosen the current regulations or legislative environment. That to me is the only way. Otherwise, if you, let's say this executive is doing something, you replace another person to respond to the same incentives. And also I look at hospitals, again, if I were CEO, I probably do the same, right? I would increase revenue, etc. When the position itself wrapped in that incentives will determine what the person in that position will do. So I would say improve the system instead of not only blaming individual player, because the incentives are wrong.
I give you that. If I was the CEO for it, I'm like, I'm not paying anybody more than Medicaid because they're willing to do the work for Medicaid rates.
Exactly. Then
so
it comes back.
Why? That's what I would argue. Why? And it's so until you're absolutely right. It's not about morality or being good or bad. It's about my job as the CEO of a company is to maximize profit for the company and deliver a return to the shareholders. And that's what they're doing, and they're doing it very well at the expense of the customer's choice and the clinician and physician workforce.
Then imagine, Dr. Rob, if there's enough public outcry against this and enough public awareness of what the root cause this is, then politicians on the top will have to change.
Yes.
That would, in my opinion, is the only avenue to change all this. Yes. So if we have complained a lot about patients not being served, physicians not happy, but politicians won't really care. There's not enough political will to change. Why would they change? Status quo is perfect. So at the end of the day, I think we have to demand, we have to ask for a change before any change can happen.
Yes.
I also, and I want to emphasize that opportunity cost is huge. We might just say, oh, this is an inefficient system. Guess what? People's lives are being compromised, right? We all have only one life to live. And a great training and aspiration of physicians are compromised. They could have served many more patients, but they can't, right? A lot of innovative minds, intelligence, innovative potential being wasted because our hands are tied. So that overall create a huge societal loss, and we're paying the price. We could not see the optimal state of what can happen. Thank you.
So for those of us who are physicians and we don't have a PhD in accounting or economics background, what do you mean by the opportunity cost? What does that mean?
Yeah, I think I came from China. I would say how much we can achieve potentially as a person is really constrained by not only internal factors, how smart you are, how healthy you are, right? Genetic factors, but also by the environment you are in. That's why many, well, if I'm in China, I might not be able to do like one thousandth of what I'm doing right now, because of the environment that's really limiting you. So here are in the United States, the most, the greatest country in the world. Everybody going to medical school when they were young probably have a great aspiration for themselves, right? And then you go through all this training, spend a lot of money and time, most important, the time, you are thinking about good several decades of service, right? And by the way, your time is limited. You don't have unlimited hours to serve your patients. So after all the training, you only have this limited number of hours to serve patients. Don't you want to maximize the potential, right? Don't you want to focus on doing good things instead of doing documentation, thinking about how to squeeze the dollar or how to fend off other things? So all the societal frictions, restrictions end up being compromising how much we as individuals can achieve in our lifetime. And that in aggregate will become a societal loss because our economy, our wealth is built solely by people's labor, by our lifelong productivity adding up. So therefore, I think we will have to recognize as a physician what we want to do versus what we can do, and how can we help remove the frictions that tying us up.
Yes, it's beautifully said. Yes, I think when you said that, so many things come to my mind. One, time is the only commodity that you cannot make back up. We will never have this moment again.
Right.
And so time is extremely valuable to each individual. And how you use that time defines what your legacy will be. And that's a very important, people in the business world often don't understand the importance of time as a financial incentive or value based. Because I'm interested in how we move from the mirage that we have created into the future. And one of the things that really upsets me is that in the US, there really is not a public health system. And one of the diseases that fascinates me, because it's a horrible disease for children, is type 1 diabetes. We can now screen children for type 1 diabetes starting at 2 years of age before they get symptoms. And the screening test costs $70. And it can prevent a very sad complication, which is called DKA, which costs about $50,000 per case to treat. And it often leaves a child with a lower IQ, developmental delays, and a lifelong struggle with metabolic disease. Yet in the US, there's no, that would be in the aggregate about, if you screen at 2 and 4, a spend of $480 million, $500 million. And if you count the lives that would be saved, which would be about 100 per year at an income of 60,000 and a workforce for 30 years, you'll be saving about $1 billion. But we don't have the money to do it. Yet we're going to spend $7 billion revaccinating everybody for COVID.
Yeah.
What is the solution, Herb?
We have to have a public, I'm all in for this conversation that the private market works best, but we must acknowledge there is a space for the federal government to have investment in long-term returns like vaccinations, screening programs that will pay out big in 20 years from today.
Absolutely. That's
and you
underinvested.
cannot have the individual, the employer, or the county government make that investment.
Yeah.
And I'm fascinated. I'm going to tell everybody, please go on LinkedIn today. I reposted the article in Forbes about the idea of giving everybody the money to buy their own premium, because I think that is the most ingenious, solution to the problem that I have heard articulated.
Yeah.
And I think that is where we need to go. And I really thank you for that article. That article was phenomenal. And the shocking part is, I'm going to get it wrong, because when you say something like, what did you say? Something like 50% of the population spends 3% of the healthcare dollars, so they don't need to spend $38,000 to insure their families. Is that
not
right?
insurance, but they don't need a very comprehensive coverage. They need a essential coverage, which will cover what you said about screening, right? Those essential preventive care, but they do not need a coverage that cover every single generic drugs, every single hospital visit. Those things can go into cash basis.
Wow.
That's the whole idea. And then imagine you can save the money and build either savings account or just overall wealth. That is the most important self-insurance that will help you fend off all risks, financial risks.
Wow.
Why don't we let Dr. Bay do some closing thoughts on the podcast?
Yes.
We're at the top of the hour.
Thank you so much, Dr. Bravo and Dr. Rogu. This is a great honor to be on your podcast. I'm not a physician. I always admire physicians, and this is really an honor. I would say we need to envision, right? We need to envision what a system can be and how much opportunity cost that we have incurred. And I do believe physicians are probably the only potentially powerful force that can drive transformation, drive change in our healthcare system. I would say it's really my only hope. I believe you have the training, you have the aspiration, and you have the love of patients and understanding of the system to really make a difference. And I think we will.
Yeah. Do
Well,
good
thank you
quality
very much for
medicine, and then the money will follow, I believe. Good medicine, the money will follow. If you follow the money, you'll never do good medicine.
Absolutely. And if you do good medicine, money will follow. Absolutely.
Yeah.
Thank you very much for your time. Thank you very much for all those articles you write. It's wonderful. It's wonderful.
Thank you for your support. I'm indebted to you.
Thank you.
Thank you very much.
No, we are to you. Thank you so much.